Good afternoon, everyone. Thank you all of you for being here today. Good afternoon. Today we have our webinar about COVID-19 care in low-resource countries. This is a very important topic for MedGlobal, as we are a medical international nonprofit funded to reduce healthcare disparity by providing free healthcare to refugees and displaced in disaster regions with which usually have low resources. So today we have the honor to have 4 speakers to discuss this topic more in detail. First, we have Dr. Riley Jones. He is an academic hospitalist and director of the Internal Medicine Global Health Program at the University of Florida. He earned his MD degree from the University of Louisville before completing his training in internal medicine and tropical medicine. He completed his master's degree in conflict security and development studies in global health, as well as biostatistics from King's College London and Tulane University, respectively. Dr. Jones' research focuses on the impact of peace negotiations on health outcomes, public health interventions in low-resource and complex humanitarian emergencies, horizontal health systems rebuilding in fragile and post-conflict contexts, and the role of the health sector in reinforcing transitions to peace. Dr. Jones volunteered with MedGlobal at our medical program in Cucuta earlier this year in February. So welcome, Dr. Jones. Thank you for joining us today. We also have Dr. Mohammad Tabriz. He graduated from Dhaka Medical College in Bangladesh in 1994 and completed his residency program in internal medicine at Queens Medical Center, Mount Sinai School of Medicine, New York. He later completed his fellowship in infectious disease from San John Medical Center at Wayne State University in Detroit. He currently works at Advocate Christ Medical Center and holds a faculty position as Clinical Associate Professor of Medicine at the University of Illinois in Chicago. Welcome, Dr. Tabriz, and thank you for joining us today. We will also have joining us today Dr. Narina Ahmed, originally from Philadelphia. She attended Drexel Medical School and completed her residency at the University of Illinois in Chicago, where she also completed her MPH and served as chief resident. She then completed her fellowship in pulmonary and critical care at the NYU Bellevue, which is also where she launched her global health career by funding the Bangladesh Ultrasound Initiative, which is a training program for critical care physicians in Dhaka, Bangladesh. Since then, she has been involved in several bedside ultrasound training programs. She is currently the head of ultrasound for both MedGlobal and Bridge to Health, giving her the opportunity to share the ultrasound training in low-resource settings such as Sierra Leone, Yemen, Pakistan, Uganda, Kenya, and Tanzania. She also helped train the entire Penn division of critical care in point of care ultrasound, and is a co-founder of the Philadelphia area critical care ultrasound program, which is an ultrasound training program for all incoming critical care fellows in the area, which launched in August of 2018. Welcome, Dr. Ahmed. Thank you for joining us today. And last but not least, Dr. Zahir Sahul, MedGlobal co-founder and president, will be joining us today as well. He participated and oversees medical missions to more than 14 disaster regions, including Syria, Yemen, Bangladesh, Puerto Rico, Iraq, Lebanon, Colombia, and Gaza. Under his leadership, MedGlobal has partnered with local communities to rebuild resilience in the face of disasters and wars, using technology and innovation, and focusing on the training of local healthcare providers. He is a full-time physician on critical care and an associate clinical professor at the University of Illinois, a humanitarian, and a strong advocate for refugees and victims of disasters, including his homeland, Syria. Dr. Sahul was awarded the Chicagoan of the Year award in 2016 for risking his life in medical missions to besiege Aleppo. The Heroes Among Us award by the American Red Cross in 2017, the UNICEF Chicago Humanitarian Award in 2017, the Commitment to Change Award by the National Immigration Justice Center, and the Robert Kirshner Award for Global Activism by Heartland Alliance, among other awards and recognitions. Thank you, Dr. Salul, for joining us today. Hello. Hello, everyone.
We can hear you, Denise.
Okay. I will just introduce our panelists today. And we are soon to be joining for Dr. Salul and Dr. Narina Ahmed. But we can begin today's topic. As I mentioned, we are talking today about COVID-19 care, as COVID-19 has become a pandemic, and we all by now know a little bit or too much about COVID-19. But it's a question for us to know what happened in low-resource countries with COVID-19 care. So I would like to begin with Dr. Riley and with Dr. Therese on how would you define a low-resource country in your opinion? Dr. Narina Ahmed just joined us as well.
Very good. Well, so I guess I'll lead us off. So low resource setting is, in my opinion, I think that is a changing definition, one that initially started out as sort of a loose to define but easy to recognize type of thing, generally characterized by a lack of funds to cover something. So money would be a major defining characteristic of a low resource setting, not necessarily geographic location, which I think is important to point out, but a low resource environment where there is not enough infrastructure or capacity in one way or another to manage the challenges that people see. One of the main things that people think about would be, all attributed back to a lack of funding, would be the access to medications, particularly if they're expensive, which would potentially be the case with a medication like remdesivir, but also would be lack of healthcare providers, which is the case in many places where they have one physician to every 100,000 people or so. And then another would be lack of infrastructure. One of the challenges that the Ebola epidemic experienced was a lack of ambulance capacity or willingness to provide ambulance capacity. Also a lack of healthcare settings for people to seek. Sometimes that can be several days ride or walk away. And I think that these are some of the starting points for a discussion about what is a low resource setting. Do I have any other thoughts on that to start us off?
Thank you. I will take the lead from here as I was asked to comment on that. First of all, I would like to thank Med Global, Dr. Salul, my colleague for a long time, and I have known him personally too, for inviting me to come and talk and be participant here. And I'm from, originally from a low resource country. Let's first say that. I came from Bangladesh, graduated from there. So I have firsthand experience what exactly it means to be in low resource country and what it means in reality. I agree with the point that you already mentioned. It's summarized very well. It's obviously financial and economic resource restraint is probably the driving force for everything else. However, as you said, It's not like just the financial aspect, it's also human resource. You know, if you have, as you mentioned, doctors to patient ratio is not appropriate, that's a low resource, or nurse or other healthcare worker, logistics and all this thing. And sometimes you have the manpower, but you don't have the right manpower. You know, for example, with the COVID-19, I give an example. This is primarily an infectious disease, right? And I'm an infectious disease consultant by my specialty. In Bangladesh, there is really no formal infectious disease specialty. There is tropical medicine, which is different than what we understand in West about infectious disease. So that itself is a low resource. You know, right now we are facing enormous challenges in Bangladesh about infection prevention and control. Healthcare workers, they're not trained, you know, what it means and how to practice even standard precaution. So with that, I would say everything else that you have said, I would say, yes, in a certain situation, low resource means what you need, you don't have it. That's what it's important at this point to talk about. Thank you.
I would add one thing. Thank you again for having me. That another resource which is critical is medical education and training, and I think that that is a crucial part of the resources that go into building capacity somewhere. And I've done a lot of, I'm a pulmonary critical care doctor by training, and also my background, I'm also from Bangladesh, born in the US, but I've gone back every year for the last few years and working with the ICU and some ICU colleagues in Dhaka, in the main capital of Bangladesh, and have seen that you know, that medical training, these are incredibly intelligent physicians all over the world, but an organized medical curriculum and increasing skills and capacity is an incredibly important resource that I think is missing in many countries. And that's just, again, due to minimal staff and inability to really support the masses of people, and then just the number of trainees.
I mean, I would agree with all of the above. By the way, welcome to this seminar. My name is Zahir Sahlul. I'm pulmonary and critical care specialist. I'm colleague of Dr. Tabriz. I've been also with Dr. Ahmed in many or several low resources countries, including Yemen, Sierra Leone, and other countries, Gaza. I've been in Bangladesh, of course, but originally I'm from Syria, and Syria is considered I mean, middle-class country that went through a rough time in the last 9 years because of the war, and now it's considered low resources country, unfortunately. Fragile state, similar thing in Yemen and so forth. In my views, besides what has been mentioned, also the attitude of the population and healthcare providers in these countries makes a huge difference in terms of adherence to protocols, trust in the authority, trust in the evidence-based medicine, and the trust between the public in general and healthcare providers. Here in the US, of course, there is respect. There's no abuse of healthcare providers. We're hearing in the last few months of doctors and nurses being attacked by the public in Yemen, in Sudan, in other places, just because the doctors cannot offer that much to treat the patients with COVID, or they cannot admit the patient to the hospital with COVID, or because someone died because of the COVID. So this lack of trust is something that is also common in these countries, which will add to the complexities. You know, just to give you an example, yesterday we were having this discussion with some of our Sudanese colleagues from Sudan, and Sudan now has about 7,000 COVID cases. The mortality rate is about 10%, and all of these numbers are definitely an underestimate because there's not enough testing. No one knows really what are the real numbers, but these are the public numbers. And she was telling me that if someone had COVID symptoms, shortness of breath, fever, and so forth, they go from hospital to hospitals. Many of the hospitals will not accept them because they do not have ventilators or even oxygen to use for these patients. So imagine yourself having shortness of breath and suffering with the symptoms, and you're moving from hospital to hospital to be admitted, and no one opens their door for you. Your attitude as a patient will be definitely hostile towards healthcare providers, anyone who represent kind of authority. And this is happening in Sudan, happening in Yemen and other places. But of course, the lack of technology, the lack of money to spend on PPEs, on nurses, training, all of this is adding to the complexities. The question really that maybe is very important for us, all of us practice in the US, and some of us had experience practicing in low resources countries or getting training or medical missions. What do you think the main differences in managing patients with COVID in the US and managing patients with COVID in low resources countries or low resources settings? And we can talk from the governance, healthcare governance, to administration, to attitude, to adherence to protocols, to the actual clinical differences in between these two settings.
Sure.
Anyone can start.
Okay. Well, if I can make one point about what a low resource setting is, there's something that I've been aware of or seeing a little bit more of, is that COVID has given us the opportunity to realize that we are all at risk to suddenly becoming a low resource setting. And I think that that's an important thing to realize, that we are all at risk for this. And then when we start to look, when we have a high resource economy and still be a low resource healthcare system, I think that's an important thing to consider. And then also to look at, what is a low resource setting versus a chronically low resource setting, and to realize the impact that that has, and also the longstanding inertia or lack of inertia of a chronically low resource setting, what that has to patients as they are going around hospital to hospital and getting pushed away and pushed away. Here in the United States, I would say that we are indeed suffering from a low resource situation, in terms of ventilators or an effective treatment. Maybe that has changed with the recovery trial, who knows? But I would say that we are still suffering. We lack the resource of a good social cohesion at the moment, and also ability to communicate timely with a consuming public. And then also our ability to manage misinformation. I would say that that we would fall under the category of a low resource setting currently in terms of those. Now back to your question about management differences between the United States and a low resource setting, or a high income or high resource setting to a low resource setting. I think that taking into consideration the chronicity of low resource, that has a major impact on how we're able to manage things going forward.
What do you think, Narina?
Yeah, I agree. I think that's a good segue to answer the question. So first of all, I think public messaging is incredibly important. And I think that's where there is a very big challenge in low resource settings. And also probably to your point, Riley, about how a high resource setting can become a low resource setting. I think mismanagement of public communication, or rather lack of public communication and transparency, hospital preparedness. So I think those are the aspects that really go into how we can prepare and prevent the collapse of the healthcare system, because that's really what all the lockdown was about, right? How can we prevent the collapse of the healthcare system? We know we're going to get a surge of patients, but how can we prevent the overuse of resources and the limited resources situation that we were in? And I think, one of the other big challenges to that end is that many of these countries started out with a collapsed healthcare system. In Bangladesh, when you walk into a public hospital, you'll see patients that are outnumbering the number of beds. They're on the floor, they're getting IVs and getting treated and monitored in the hallways. How do you then go from a healthcare system that's already extremely overwhelmed and treat and identify patients? I think the answer to that is that in that challenge lies innovation, the solution is innovation. And I think really getting creative and innovative about the solutions in a scenario where you start out with limited resources, you start out with limited public messaging, limited ability of that organizational structure and hospital preparedness. Those are things that are not necessarily a part of the normal system. I work work in a very large academic university system, which has hospitals all over Philadelphia and South Jersey. And I think one of the biggest strengths that we see in these large hospital systems is that network of communication, the ability to communicate not only with each other, but with the hospital physicians, the healthcare work, all the healthcare workers, nurses, RTs, et cetera, as well as the public themselves. So I think that ability to communicate is so important, and that structure that is inherent to many of our systems here in the US. Yes, our response was even limited, but even that ability to organize was so incredibly important. And that's one of the biggest challenges outside of the obvious lack of physical resources. And I think it begs the question, you know, people always laugh when I say I'm a critical care doctor that's doing global health medicine, and they'll always say, well, ICU medicine is, you know, it's something for rich countries, right? But I think the trick is to redefine what critical illness is, and it's about catching these patients early recognition, early detection, and I think that's the real solution in resource-limited countries, is to prevent these patients from ever needing the excessive resources that they do need when they're in the ICU. So I'll pause there.
I would add a few points here. The question was whether the response in Western country, including US, is better than what has been response in resource limited country. You know, the healthcare system that we live in is not prepared to face the pandemic that we have just encountered. You know, if you remember SARS and MERS and H1N1, we did not even prepare at that time, and we got lucky about it because not too many cases came. I remember I was a fellow in 2003, and then we talked about the SARS and things like that. So we didn't learn from the previous risk that we faced. Luckily, we just did not have problem. So the response that I'm looking into this COVID-19, obviously there is a healthcare and scientist community, and there is a political community who actually will give the platform for the healthcare community to work and face this kind of situation. And I would say in that regards, almost every country failed in that regards, including US. The administration, the political, the elite did not take the hints that it's coming, we need to prepare. And unfortunately, the resource limited country followed the same same pathway. You know, I remember, you know, when I saw my first patient on March 12th at Advocate Christ, that was the first case I diagnosed. And even a couple of weeks before that, I was in touch with my colleague and other friends in Bangladesh. And we talked about all this thing in the ministry, the health department. They all talked about it a lot, but in reality, they did not really take it as seriously. Some even said that it's not going to come in this temperate country because of the temperature, because of the other, you know, environmental factors. It's not going to affect us much because H1N1 did not affect. So those attitude from the political, platform was not correct. It's happened almost every other country too. And despite getting this almost 3 months after the US started having the surge, the resource limited country, whatever resources they have, they did not really prepare. They did not prepare. The response, I can tell in my home country, in Bangladesh, my motherland, was like, well, we're going to prepare only few hospitals for COVID dedicated patient, and then rest of the country can just sleep and do nothing. We'll just manage that way. That was a wrong approach to begin with. As you know, Dr. Saulul just mentioned, it's not only in other countries, it happened almost every country that we heard, and I have witnessed myself, my relative also, where patient will be going to a hospital and they will say, well, we are not treating anybody other than COVID. If they go to COVID hospital, then they will say, well, you're not tested positive for COVID yet. Why don't you go and get it tested, which doesn't happen. So I think the response has been very problematic in resource-rich country, as well as resource limited country as well. We did not really do very well in that regards.
I mean, I totally agree. And yesterday there was this radio interview with global health expert who mentioned that somehow, even in the US, of course, all of us agree that the national response from the leadership was delayed in response to the COVID pandemic. And that translated into more people who got infected and even died. If we had this response of lockdown, preventive measures, social distancing, testing, tracing, contact tracing from the beginning, that means in February, we would not have 2 million people and 115,000 people dead, 2 million people affected, 115,000 dead, and we're expecting more, 200,000 by September. And this is only in the first wave. So we have failed in the United States of America, the country that has the most expensive, let's say, not the best, the expensive healthcare system. We spend more per capita than any other country in the world. And CDC, which is the model of an organization that's supposed to be preparing a country like the US and the world for pandemic, has failed. And I think we have to be blunt about this. But in terms of the national responses in other countries, and you know, again, we talk about Bangladesh, Pakistan, Yemen, Egypt, these countries that right now have high rising numbers of infected patients. And at the same time, they did not take the issue seriously, knowing that you will have more morbidity and death among the population because of that. How can we explain this attitude? I mean, as a government, the main goal of the government is to protect people and make them safe. How can we explain that this is not happening in many countries in the world?
If I can add a couple of my thoughts, a couple of points. You know, the problem is, as I said, there is two different part of the, you know, leadership that needed to come forward and do this, and in coordination with each other, which is the government policy making and then the scientific and medical community. And if you don't have the leadership that has the, you know, the right attitude, and they just feels like everything is all right, and there is some political agenda also, because if you say, well, this is coming, then you don't have the preparation, then you lose your popularity also. So that's obviously the lack of the correct leadership, and also not the right person in right position. If your health minister is somebody who doesn't understand what is infection, what is pandemic, how do they spread, and basic principles of prevention, then obviously they are not taking the right lead. And top of that, if they're not putting the right person to lead this crisis, okay, I don't know, but I have at least the leadership. I can put the right person in the right position, and they will lead me what to do, what to do correctly. That didn't happen either. So there is obviously political corruption and lack of expertise and lack of this right attitude. That's what's obviously a lot of problem that happened because of that.
Yeah, I would agree that I think political infighting and all of a sudden healthcare becoming healthcare and politics, it's not necessarily new, but becoming such a problem where the two are interacting to the extent that politics is now becoming obstructive to a response. And I think especially in many low resource countries where maybe, and this isn't necessarily a fully generalized comment, but if the government, I agree with what Dr. Tabriz is saying, that if the government is not on the same page and open to identifying what some of the weaknesses are in their own healthcare system, then they're going to be unable to respond to them. And I think if there is mistrust, you know, something I've seen a lot in Bangladesh as well as many other countries is that there are several organizations that are trying to do the same thing, but they will not collaborate with each other. I think one of the biggest things that you have to do in this kind of a situation is cross-disciplinary collaboration. There has to be collaborative efforts across every level of government, every level of healthcare, between private and public. And again, I think there really needs to be communication across country lines and how we learn from each other. I think these webinars have really been incredibly helpful. I remember early in the COVID response, I'm based in Philadelphia, and I would join all the New York City webinars so that I could learn from what they were experiencing in New York, and so that we could apply that here in Philadelphia, given that we were a few weeks behind. Those kinds of things are incredibly important, but people need to listen to each other, need to communicate to each other, and I think that's one of the biggest things that's missing.
Riley, do you wanna add anything, Dr. Jones?
There we go. Okay. So yeah, of course, I'm not at all surprised by the heterogeneous political responses to different and different perspectives on what to do with Corona, what to do about it or not do about it. You know, I'm always reminded back to one of my favorite books by David Keane. He titled the book "The Benefits of Famine." And even though there's something catastrophic coming, there are people that will figure out how to exploit something and use it to their advantage. I'm not going to go so far as to say that anybody is actively doing that, but it does make me wonder. One of the things where we have the opportunity to learn and anticipate from other areas where there has been a deep and damaging impact on a society would be in the areas of complex humanitarian emergencies, where or natural disasters, large natural disasters that break out over a regional setting and stay chronic, would be the situation where a population grows fatigue and fatigue with their unmet expectations of a rapid recovery. And oftentimes that can lead to a general change in the political climate and tolerance for political inactivity. So maybe that could be a silver lining. Maybe it heads in the wrong direction. But I'm not at all surprised that that there would be such a varying response. One of the areas where I think it's been interesting has been seeing with Iran, the different approaches of some of their regional partners. The UAE did send some aid. Bahrain did not respond in quite the same way. That's been interesting to see. The other thing has been in some of the different regions where you would see unexpected warming of relations. I know that when I was in Colombia, the ELN, they suddenly said they declared a unilateral ceasefire because Corona was coming. And then also in the Philippines, President Duarte unilaterally announced a 1-month ceasefire against communist rebels. So there are a lot of interesting aspects that I'll probably spend the next 5 years trying to digest.
So the one other thing what I think is really important to recognize also is the dynamic that exists in many of these low resource countries when you have such a large majority of the population living under the quote unquote poverty line. When you're thinking about that, you know, for instance, let's say Bangladesh, you have so many people that are garment workers that are working in factories that their livelihood and the money that they're making is what puts food on the table for many people, and it's many women that are factory workers, and just think about the number of people that are affected when they are told to be told to stay home, and that lockdown and the economic effect that we've seen in our own country. Now imagine that in a country where the economics are already in hardship and people are suffering from poverty and famine and needing that money, even that little bit that they might be making. Just imagine how much that matters to a family that is already struggling. And I think that's really challenging, as well as to think about education in countries where, you know, we're seeing a very disparate effect on women, that although the statistics are showing that men are suffering more from COVID than women, but think about the fact that now the woman has to take the charge of the family dynamics and about schooling with children dropping out of school, and that inability to maybe even ever go back, and what that means as an impact on the community. And I think in low resource countries, we are seeing such a bigger impact on the community level outside of just the disease itself. And that I think is almost feels irreparable at this point. But I think that's a huge part of the dynamic. And I think the challenges that some of these governments face in completely shutting down because of the effect that takes on people that really rely on their day-to-day salary.
Along the same lines, probably, or connected, is the what Dr. Pareja probably we're going to be addressing. Denise is, by the way, from Ecuador originally, and Ecuador is also hit hard by the pandemic, especially in Guayaquil. So what do you think, maybe you can ask the question, Denise, about the community engagement and how important is that?
Thank you, Dr. Salul. Yes, just for a background on our audience, Ecuador is a...
Can you turn on the video? I think for some reason it's frozen. Right.
Hello? Okay.
Yeah.
Thank you, Dr. Salul. In Ecuador, Ecuador is a country that one of the most heated countries in South America with COVID-19, and the response in Ecuador was also very similar of what Dr. Ahmed was mentioning about engaging the community, and also the engagement between the health sector and the government. We started our response in Ecuador, in Guayaquil, providing counseling on how to do epidemiological practices, such as case tracing with the municipality in Guayaquil, and currently we are now working with the Santa Elena, which is another province, the Santa Elena Governorate, by teaching healthcare workers, healthcare promoters who are going to be reaching the community through medical missions, and also we will be training nurses and general practitioners that will be treating mild COVID patients. But definitely in Ecuador, tools like technology tools that are allowing us to train online people who are going to be in contact with the community is very key in these moments. Also, in Ecuador, for example, in Santa Elena is a province located in the coastal area. So most of the province is a rural area, and the majority of the population there are farmers or fishermen, and they work day to day. So of course, when the policies from the government started, the home stay at home orders, it was not respected by the community. They did not take it well. And this is something that we are going to work with them in the future to know what perceptions and how culturally advantages we as health leaders can take into consideration, so the community can be more engaged and more aware of how they can prevent this, and how at risk they can be by such a pandemic such as COVID-19. So with this information, I want the panelists to let us know, what do you think, how important it is to engage the community in low resource settings, and how will be the best way to approach them in a context of COVID-19.
Maybe we can start with Dr. Tabriz, then Dr. Ahmad, then Dr. Jones.
Thank you again. I think it's absolutely very important, because, one of the thing is, as I initially mentioned, one is the healthcare system that we work in. The other thing is a public health crisis, like a pandemic. They're two different things. And in general, healthcare system and resources are so limited in those countries, so they cannot even provide basic treatment, even for diabetes, hypertension, things like that. So in that regards, this is absolutely important, how we prevent this not to get into that huge number, which we already probably missed the opportunity in some countries, including Bangladesh and Pakistan and some other countries. So the communication, why it is so important, in my view, I can give you some real life example. A few days ago, one of my friend, he's a physician, said that, he saw a patient who had all the typical symptom of COVID. They had the constitutional symptom, they had the respiratory symptom. He was even able to do a CBC and a chest X-ray, which is very classic for COVID, right? And then he cannot do the testing because the testing is so limited in Bangladesh. It costs about 3,500 taka, which is probably close to $40 or so. So this person who's not going to be able to pay for it, if they go through the government, which is free, the government facility for the testing, it takes about 2 to 3 days just to get the testing done. So what he was suggesting to this physician, this patient, is yes, it looks like you have this, you just need to go home and you need to because it's not a severe disease for him in this case. However, the patient would not actually comply with this because if he doesn't have the complete diagnosis positive, he will not go back and quarantine himself or isolate himself in this case because this is symptomatic already. So this communication, because he's also fearful, if he goes back to his community, the other members in the community will look at him as like stigmatized him, will not be able to mix, will not be able to go to the marketplace or so on. His family will be suffering. So this communication, this real true information for the mass people is so important to go by their daily life. Another example, I think it has improved since then. There were physicians, there were healthcare worker in some area. If they were working in a COVID hospital, then they would not be able to even go back to their home because the home, landlord or the neighbor, they will think, okay, this doctor might be spreading the infection among us. So these are the few examples. Even the other thing is the general people even wearing PPE and walking into the marketplace with wearing a whole coverall. So there is a lot of misunderstanding, misconception, fear, stigma. These are happening there. So this communication is very important. How we can do that in a resource limited area? You have to look at the cultural and what is the regular practice. In some cases, we may have to engage the religious leaders like mosque, imam. In some cases, it could be temple or the priest who actually can lead more people than some doctors. So those things need to be considered. And in some country actually, for example, in Bangladesh, I think it's less than 10% people actually go to the real healthcare professional for their healthcare. It's actually by the so-called village doctors. Sometimes they are just the pharmacy salesmen who actually provides the medication without even seeing a doctor. So that constitutes a large, huge number of healthcare providers in many countries, including Bangladesh. So we cannot just ignore the fact that they need to be involved in this kind of crisis to face the crisis. We cannot just say, okay, yeah, they don't have the medical background, they don't know what to do, let's just put them aside, we're going to do everything. They need to be trained, they need to be given the right message, and the population can then be benefited without much resource needed. Whatever existing resource available, that need to be corrected and that need to be utilized.
Sure. Nahreen, what do you think?
Yeah, I agree. I think every country is a little different with who the population and the community trusts, and I think public messaging is huge here. And how we define, if we think about what testing was like in the U.S. in the beginning. I remember when we were first ordering tests, it would take a few days to come back until each institution would develop their own rapid testing, and that may be something that doesn't come for many of these countries. I think the important thing is that true public messaging in the same manner, in a way that the community will receive it. Something I think is really interesting on this level is, every time I travel to a different country, I find that everybody communicates differently, meaning that in some countries, Facebook Messenger and Facebook is the #1 way to get in touch with somebody, more so than email or a cell phone number, or WhatsApp in other countries, or Viber, or other messaging services that exist. And I think utilizing messaging services that people trust, that people use, that people watch. In Bangladesh, it's always Facebook. If I want to get in touch with somebody, it's via Facebook. Everybody is most responsive to that. Is there a way to distribute public messaging such that the majority of people will see it on a form that they're used to, and social media, we're using that in so many ways. Are there ways to communicate that would be advantageous for each different country? And I think that public messaging is incredibly important, as you mentioned, and really the correct messaging. And I think somebody mentioned this, I don't remember who it was, but how to correct misconceptions. Because as we saw here, there were so many misconceptions that came up about COVID, and proper social distancing and what that means, and how to prepare or keep yourself safe and empower yourself in being able to prevent transmission. I think those conversations are most important in really correcting those misconceptions. And there are so many of those in so many of these countries because, again, the public messaging is really riddled with problems.
What do you think, Riley? Anything you want to add?
Yes, of course. So to go back and just catch everyone up on the question was how important is it to get community engagement? And I'd say it's absolutely critical, and I would rephrase it. I would reframe it in how successful have our governments been in handling it for us, and realizing that the situation we are in right now is that it's not just critical; it's the only option. Is that community engagement is going to be our way out of this. There have been a couple of examples where community engagement has been able to fill in the void where government strength has not. One that was just highlighted in a paper by Preeti Patel is in the Idlib province, where there's a lot of government complexity. We'll call it control complexity. But one of the things that has helped to limit the spread of COVID, to the best of our knowledge, because testing is difficulty. But one of the things that has led to an improved response has been the Volunteers Against Coronavirus, which was set up early on by the Idlib Health IHD.
Mm-hmm.
And then and their coordination with the White Helmets and several other health groups that they set up early on. And one of the things that they did, this was a community grassroots effort, and it was a very active WhatsApp group and Facebook group, and they were able to do contact tracing, isolation, and they did this at the community level where there was not the government infrastructure to fill in the void. And I think that going forward for any place, that's going to be, I'm going to say, the majority of our exit strategy. And I would say that part of the civil unrest that we have here in the United States was going at it with a problematic expectation that our government was going to magically make this go away overnight. And I think that has led to a lot of the confrontation and the infighting that we have seen here.
So I'm going to shift gear a little bit here to hospital responses to COVID. In the US, in the hospitals that you're practicing, and comparing that to some of the hospitals that you are aware of in low resources countries or from your colleagues. You know, I mean, this is an anecdote. Yesterday I was reading a report about one patient who was admitted, I think in Seattle, to a hospital with COVID. And he stayed there for 42 days, and his life was saved. But then he received a bill for $1.1 million that Medicare will pick up. Another patient in New York who has no insurance received a bill for $400,000. Then they gave him a discount, $350,000. I think one of the major differences between high resources countries like the US and low resources countries, that most people in the rest of the world pay out of their pocket for their health expenses, including hospital admits, including medications, including blood transfusion, including IV fluid, including supplies. And this is something that we are not aware in the West. So some people may actually prefer to die at home than spend all of your saving on healthcare. In one of our medical missions in Sierra Leone, we had a young patient who came in with symptoms of appendicitis. She was 16 years old. And then we had a surgeon with us who told her that she needs a surgery. And then her family refused actually to have the surgery by this surgeon who came from the United States. And we asked them why. They said, we don't have $100 to pay for the hospital. Of course, we paid for the $100 and we had the surgery, and her life was saved for appendectomy. But imagine yourself in Yemen or in Sudan or in Syria, where you want to be admitted to the hospital, but you don't have the money to be admitted, and you don't have, of course, the expenses of that. So the question actually is, my hospital had been planning for the surge of patients for at least 6 weeks before the surge. So we had PPEs, we had planning on how to convert floors to ICU floors, if we need to get more ventilators, to communicate to the house staff, how to use your PPEs, train everyone how to manage these patients, started to write protocols based on what we know, all of these things. What are the differences between hospital responses in Bangladesh or other places and our US response? And maybe we can start with Nareen, then Dr. Riley, and then Tabriz.
Sure. So I think one of the things that we noticed early on in the response in Bangladesh was that there were COVID hospitals that were designated. What this led to was that, I think the thought behind that was, if we put everybody in the same hospital and cohort them, then it protects people that are in other hospitals that are non-COVID. I think the biggest mistake in that thought process, which might be similar in many other countries, is that we're assuming that patients will decide and be able to go to these hospitals and know ahead of time that they have symptoms that are consistent with COVID. What have we learned from COVID, though? That we have to have a really high suspicion that everybody has it until proven otherwise. And anybody that shows up to a hospital, that hospital needs to be prepared. And so as patients were showing up to non-COVID designated hospitals who truly did have COVID, they didn't know. And so they came to seek help because they weren't feeling well. And many of those healthcare providers were unprepared with PPE because they were not a designated COVID hospital. And I think the lesson that is learned in several of the hospital settings that we've all worked in as well is that, yes, cohorting patients is the right response. However, every hospital should be prepared for COVID patients and should be putting patients in separate units based on COVID versus non-COVID, but not necessarily designating the hospital itself. And then I think the other thing is really making sure that there is a lot of focus on donning and doffing of PPE. I think what we're seeing is a lot of transmission that's happening with healthcare workers in low resource settings, and it's not maybe fully understood why that's happening. And investigating that further, it might be that there isn't enough training about donning and doffing and the importance of that process in protecting yourself as a healthcare worker. And I think those are some of the things that early on I was noticing in Bangladesh that were challenging in the response, as well as overall this thought process in many countries was to task shift. Bangladesh is an interesting country because there are many wealthy people, there are many large factories and things like that, organizations that have very high capacity. And what people were seeing was that overall the public wanted to help each other. There was a lot of task shifting to building mechanical ventilators and devices that would help support patients. But I think just things like the basics, oxygen, constant supply of oxygen, hospital maintenance of a central supply of oxygen, things like that were maybe being missed, and there was too much shift on things like ventilators. I think in places like Bangladesh, by the time you're on a ventilator, it's very challenging to sustain somebody in a low resource country once they're on mechanical ventilation. And I think those kinds of things, really focusing in the right areas. And another thing that I noticed was that the guidelines that were distributed by the National Health Ministry in Bangladesh essentially were identical to what we were seeing early on in the US. Now, how can you release guidelines in a low resource country that are exactly the same as those in a high resource country? And it means we're ignoring the fact that those resources don't exist in the same way. And so it's very challenging when national guidelines or guidelines that are being released are not titrated to the resources that exist in that country. And I think those were the few things that I noticed early on that are quite worrisome in the response in low resource countries.
Dr. Tabriz, you probably have experience. You told me, you shared with me the experience about putting the guidelines for Bangladesh. Can you expand on that and maybe on the same also question?
Sure. Yes. Narina touched base few things that I was going to talk about. So this is a completely challenging situation for even US, as I said, and every country had faced challenges in terms of how to manage the patient, at the same time protect the healthcare and protect the community, right? So in Bangladesh, the main challenge is, there is no concept or practical concept of infection prevention and control. And that was the biggest concern to provide care for COVID patients. That's why the hospitals, were not prepared to accept the COVID. And then from the US and other country, UK, a lot of us try to talk about different aspects of infection, COVID and infection prevention and control. So Bangladesh Director General, the national guideline that included a lot of things from World Health Organization, CDC, but that were not tailored or catered to the, whatever resources available. So we, a few physicians from UK and, from US also, we have put together almost like a supplemental guideline, from our experience. And I actually wrote a chapter on that, infection prevention and control, which basically a few pages of very basic thing, what you would consider in US, like it's a very basic, very simple thing, what is standard precaution, what is contact precaution, what is droplet, how COVID is spread, what are the few things we can put into place, and where are the barriers. So these few pages that I summarized, it was actually included in national guideline in 6th and 7th edition. Same thing in the ICU management was drafted from this, outline that we have provided in that comprehensive book in the national guideline that was written by one of the intensivists in Indiana from Bangladesh, Dr. Tasbirul Islam, and so on. So obviously, the guideline is necessarily, it's a very comprehensive, but it cannot be implemented in a different part of the Bangladesh. For example, what can be implemented in the capital cannot be implemented in a small district or sub-district level. So, so the challenges that, what we see in US and comparing in Bangladesh, again, the infrastructure to handle an infectious disease is not, it doesn't exist, Few example would be, for example, even if you put a triage system to separate the suspected COVID and non-COVID patient, how do you then manage if the non-COVID patient goes to a general ward, but after 2 days, 3 days, we are seeing even in our hospital, people are infected in the hospital because of some asymptomatic or pre-symptomatic healthcare worker, might be infecting, or maybe another patient, next patient that came next day are infecting. So this system does not exist, how to triage them. And then testing is also another problem. The result comes after several days and very limited number of testing. So as you know, the suspected COVID patient ideally should be put it in a single room, right? That's what we do. The guideline is if you have all the confirmed cases, you can put them together in a ward. But ideally, suspected cases, until they're confirmed or ruled out, they should be put it in a single room. In a resource-limited country, you cannot do that because you have, let's say, 100 suspected cases and you have only like 2 wards and there is no single room at all. So actually WHO provides some guideline from resource-limited country. And in those cases, yes, we accept the fact that, yes, that cohort, they will be also cohorted, but they need to be separated at least, WHO said that 1 meter, but in my view, it should be 6 feet, like close to 2 meters. And then how do you manage them in the hospital setting? The country that, like Bangladesh or any other, country are facing the challenge, it's not only just one thing. You identify who are the suspected cases, you put them in the ward, but then how do you support them in the hospital? I have a very close friend who is currently, they have a relative who is admitted in hospital, but the hospital cannot provide the personal care for the patient. If they need oxygen, who's going to monitor the oxygen? They don't have enough nurse. As you know, there's like 2 nurses for 10,000 people in Bangladesh. There is probably 5 to 6 doctors per 10,000 population in Bangladesh. So even Africa, that number even low. There's less than 1 doctor per 10,000 population. So those are the challenges. If you put a suspected patient, what happens is the attendant or visitor who is not a COVID or suspected COVID, asymptomatic, they are coming to the hospital to support the suspected patient while they're in the hospital. And the challenge is they're probably getting infected in the hospital, going back to the community, and they're not able to actually quarantine themselves. They're not able to isolate the patient. So it's a vicious cycle. One patient, suspected patient might be infecting others. Those are the challenges I think the country is facing. And in terms of the treatment, they're also facing the same challenges. We are jumping into whatever the cheap drug available without having any trial. In US, as we know, the main treatment for the COVID is supportive care, right? But because they don't have enough supportive care, because they don't know what else to do, those cheap drugs, hydroxychloroquine, azithromycin, ivermectin, whatever is cheap, they're just using left and right up until most recent weeks. So those are the challenges are different. I mean, we have used that too, but we have some reservation. Okay, I'm not going to use on everybody. In the community setting, we're not going to use it. That's one thing. The hospital is basically another biggest challenge is, as Dr. Narin said, that how to protect the healthcare worker. They're coming up with different kind of ideas, which is basically, I'm not sure how, it can be even implemented practically. For example, I'll give an example that in Bangladesh and India actually, I think the idea came from India. So they have a roster system where a team of healthcare workers, the doctors, will work for 7 days in a COVID and suspected COVID units. Then they will quarantine themselves in a hotel away from the family for 2 more weeks. And after that, they will go back to their family for a week and then come back. So that means you are basically utilizing a set of doctors and healthcare workers for 1 week per month. That's causing severe restraint and limitation how many patients you can treat. That one, in my view, it's not only just causing problem with the limitation of the doctors, it's also probably increasing the risk of infection. How? Because if you don't spread the patient, because you're putting all the suspected patient in a ward, right? If you don't put them 6 feet apart, because you don't have enough healthcare worker, so what will happen is patient will be more congested again. Instead of 6 feet, they're putting patient in 3 feet apart or 2 feet apart because they don't have another ward to open up because they don't have enough healthcare worker. By that, you're compromising your infection prevention measures more. So those are the challenges what I see, day to day. Healthcare workers are getting infected despite all these things. We have a very, robust system where we watch each other if we're doning and dofing. Everybody is basically trained in real life, not just watching the YouTube video and so on. But over there, if somebody is coming out of the ward, they cannot even take off their PPE because there's no place to put it on. So they're walking out with the PPE to the doctor's room, corridor, bathroom, break area. Those are the vulnerable time and point where healthcare workers are getting infected. It's not just the proper doning and dofing, but it also how you manage, you contain the infection. There are enormous challenge, no doubt about it, but there is also lack of understanding how to tackle them.
Very depressing, Dr. Tabriz. Dr. Jones, what do you think? Riley,
let's see. Yes, sir.
Yeah.
So I will try to take a more optimistic view. So I look forward to the opportunity for us to maximize our utilization of positive opportunities. So there are some things that our community is doing very well, and I think that we should learn from that, and where it's contextually appropriate, I think we should pursue that to the fullest extent. The other thing that we should do is, even though we are working in some very resource limited areas, we do have the opportunity to maximize to a Six Sigma type of specificity exactly what we are doing in terms of our management. And so if there is and this does get into a distributive type of justice where we're looking at, do we put somebody on high flow nasal cannula 40 liters per minute versus do we put 6.5 people on 6 liters per minute, because that's the maximum benefit you're going to get from a nasal cannula. That's 6.5 person days without aerosolization, or to use low low technology solution. So that would be an oxygen reservoir on the chest. There are some things that we can still do and really maximize our ability with the tools that we already have. Those are the things that I look forward to us doing while we are, we're still sort of reeling and on our heels. It's time, we're going to have to take steps forward. Fortunately, it seems that the two things that we, yes, it is a lot of supportive care, but maybe with the recovery trial, dexamethasone is a widely available medication if that indeed works. And then good old-fashioned heparin, those seem to be the two things that are reasonably available. And then we also have the good fortune to live in a time of unprecedented ability to communicate with one another. And that means we are able to beam our expertise and our experience to even the most far-flung places. And I think that we have a reasonable ability to help people out, to learn from our mistakes in other places. So I would agree with Dr. Tabriz. We should not be putting our healthcare system in quarantine for 2 weeks only to bring them out, but to learn from other areas where things are working. There was the BMJ article where they showed that the proper checklist use of PPE, that does lead to much fewer healthcare worker infections. And then when you really get to the bare bones of what do you have to have for PPE and what is sort of a nice, heated leather seats approach to PPE, these are things that we are able to effectively translate into low resource settings. And that's what I look forward to. So I do have a twinge of optimism to us going forward.
In the last few minutes, and we exceeded our time, but I think it's important to highlight certain differences in the way that we manage patients in the hospital. Of course, all of us are familiar by now of the sets of clinical syndromes that COVID can cause to the patients. We have the acute hypoxemic respiratory failure related to the COVID pneumonia or COVID ARDS, and that requires certain management. We have the COVID-associated coagulopathy that requires certain management, usually with heparin, but you need to monitor D-dimers on a daily basis if you want to do that. Then you have also the COVID-induced cytokine release syndrome that also requires certain sets of daily labs, CRP and others, and of course, anti-interleukin 6 treatment if it is available, or Decadron. So what do you foresee, I mean, in each one of you, the differences between how we are managing these 3 sets of syndromes related to COVID here and in low resources countries? What will work? What will not work in low resources settings? Or available, actually, not both will work, but what's available?
Yeah, I think to Riley's point, utilizing what is available and knowing what works. Steroids are readily available in most places, and I think talking about the timing of their effectiveness. I've always actually been a fan of utilizing steroids. I had mentioned this in the last talk we had about treating patients with COVID in the ICU. Frankly, I think sometimes by the time they get to us in the unit, we miss the most opportune window potentially, right? So I think now we need to think about, we've come up with all these guidelines about the timing of anticoagulation in hospital, but I think the most important thing to think about is how can we use what we know and think about the timing and where we're actually administering those medications. There are a lot of creative thoughts about, can you create a hospital an isolation center where you are isolating patients who are mild to moderate disease at most, and retiming when we're giving anticoagulation, and not necessarily with patients who are severely ill, but thinking about those mild to moderate patients who require oxygen. Is the timing of starting steroids, do we need to change that? Do we need to think about, in these particular patients when we're not necessarily able to get the feedback of CRP, of IL-6 numbers, those labs are not necessarily readily available in all of these countries, even just an arterial blood gas at that. So thinking about how we can use what we know, maybe particularly think about the timing of it and where and when we're treating these patients, and thinking about, somebody mentioned, can you create almost a home ICU? Well, that I think is a little challenging, but what if you were able to keep patients out, maybe just those that need a few liters of oxygen, and if you had a way to monitor them with technology, telehealth, things like that, is there a way that you can prevent people from coming in? I don't know the answer to that. I think what scares me is, having seen patients deteriorate so quickly, I would worry that if you're at home on a few liters of oxygen, you miss the opportunity to get to the hospital when you need to. But I think thinking outside of the box is probably one of the most important things, that there are a lot of medications that are readily available, and I think that when to utilize them and how to utilize them in low resource countries is probably the most important point. And then the other thing I would mention is task shifting, I think has been a really big thing that I've noticed here. And what I mean by that is taking people that don't normally work in an ICU. This is the example that I can give. We're taking PAs, NPs, fellows, and physicians that are normally maybe on the surgical side or other departments, and we're bringing them into the medical ICU to help us. And how are we doing that? We're training them, we're capacity building. Is there a way to do that to increase the number of staff and attendants that are helping to care for these patients, so that we have a bigger physical resource of human beings, because that's also a really big part of this. So really thinking on how to get creative and how to respond, because I think that's how many low resource countries have tackled some of their big problems.
Dr. Jones, are you going?
Oh, no, I can defer for now.
Okay. Yeah, I think, obviously when I was talking about the challenges, that was the part one. And I'm very optimistic and positive too. What I said about these challenges is those need to be addressed and can be addressed in a resource limited country. Because no matter what country and what situation we're living right now, the pandemic, created a very different environment that we have to work with. Even in US, as you know, in many, hospitals, for example, the infection prevention control is a different kind of, CDC has this 3 different category where, sorry. Okay. Where you have this conventional way of practicing, and then you have the contingency plan, and then you have the crisis plan. Basically, I would compare the resource limited country as if this is a crisis plan at all time right now. So those challenges that I have mentioned in infection prevention and control, some of the challenges is difficult to solve right now, but need to be modified so that we can work at least and minimize the risk. Meaning the risk is not going to be zero. As you know, there are almost more than 62,000 healthcare worker has been infected in US even. And in resource limited country with maximum protection, still there will be infected healthcare worker. However, with correct attitude, correct understanding and scientific method, some of this can be changed. PPE, what exactly a physician need when they see the patient, what exactly a nurse need when they're seeing patient versus a nursing aide or somebody food server. All these concepts are lacking. Everybody is very scared and panic. Everybody is thinking they need to cover head to toe. So this need to be changed, and then PPE should be correctly used, and hospital environment, visitors and other things, all this can be modified to a certain degree so that it can be reduce the risk of exposure for the healthcare worker with the right protocol and attitude. In terms of management, we have learned, as I said, at the end of the day, 80 to 85% of the patient will be getting better with just supportive care. In resource limited country, the demography of the patient population also changes how they are going to do. The number that we talk about, 80%, 82%, 83% is from US, China, and other countries, but very limited resource limited country. Based upon their young healthy population, their number might be different. So taking into consideration of those numbers, I think, if we ensure few things, one is access to the hospital, increase the number of hospitals where they can accept the COVID number patient. The hospital, if it's not available, but the field hospital kind of concept where their basic treatment are available, which is basically just supportive care and oxygen and good communication and referral system, which can be done because of the lockdown, there is not too much car and other traffic jam in the area. That's one of the challenges. If you want to transfer a patient, you don't have enough time sometimes. Some of this thing can be managed in a different way, so that if we can ensure oxygen, which is actually in Bangladesh, they're actually doing now. They're improving their oxygen supply. Central oxygen supply is not available in any hospital almost. But now they understand, they're installing the central oxygen supply. And I know there's high flow nasal cannula, they're purchasing them and providing in most of the hospital. That oxygen is the basic thing. That's most important thing, supply of oxygen. And then moderate to severe cases, they're already using this steroid. The number 3, in diagnosis and testing, there's a lot of limitation there. What the national guideline and the other country can do the same thing. Instead of relying on the confirmatory test, just basic clinical diagnosis, possible, probable, and confirm whoever tests positive. Based upon this clinical criteria, if they manage their patient, I think the outcome would be better instead of just testing everybody. So those are the basic thing, and anticoagulation, obviously, those are the basic thing can be still done, and mortality can be reduced, and some, the care can be provided most of the, patient population.
What do you think, Dr. Jones?
So as far as, I would echo what both of you have said for now. As far as what can the healthcare community in high resource settings, what can we do to assist low resource settings? And Emma, this will answer your question as well. The things that we can do is number 1, I would say we need to remember that as a healthcare community, we have all taken an oath, and we are all, and I don't think that there's any doubt about this, but we are all in this together as healthcare providers all around the world. As providers in high resource settings, we do have the ability to spend some time to focus on finding treatments that work, finding treatments that don't work, condensing all of that information. One of the big challenges of coronavirus has been just the fire hydrant of information that is coming out, and trying to sift through that and figure out what is usable and what is not, and identifying the subtle features deep in the papers that make these apples to oranges comparisons. The early Chinese data on mortality, in China, they do not routinely use heparin. I believe that they are now. And so when you're seeing mortality differences between early corona papers versus what we're seeing now, there are some subtle differences that might not be readily apparent. I know that right now, recently, maybe a week or two in JAMA, there were a couple of letters to the editor about the use of proning in patients, awake voluntary proning. Some of my colleagues and I, one of the problems that we've seen with those papers were they had 2 papers and both had an outcome that were different, and neither one of them happened to look at some of the statistical assumptions that the papers relied on. And for us, when we have the luxury of being able to sift through those papers, understand and interpret those papers, so that those are usable for folks who are the wave is hitting them and they are overrun and they don't have time to sift through 20 different papers on the same biomarker. That's one way that we can help, in addition to finding the next remdesivir.
Right. I mean, this is very helpful discussion. I know that we can spend the next 2 hours discussing issues related to the differences and what we can do. We need to wrap up this, but the last minute, each one of you, give me your impression about what do you expect the trajectory of COVID in low resources settings to be in the next few months or so. Do you expect worsening of the situation, things are getting under control, or what else? And what's the role of the WHO, an organization like ours, like MedGlobal, that have been sending PPEs, sending oxygen concentrators, sending medical supplies to Gaza, to Syria, to Bangladesh, to Pakistan, to Ecuador, to Yemen, Sudan, and also providing training what do you think we should be focusing on? Maybe Narine, and then Dr. Jones, and then Dr. Tabriz, and then we can end.
So the first part of what to anticipate, I do think things are going to get a little bit worse before they get better. You know, as countries are trying to catch up, you know, I think that's where we'll see the numbers rise, and as testing increases, we'll see, you know, more numbers, and I worry that I do think we might see a full collapse of the healthcare system in some countries before they can start to reel things back in. And I think what that means is that for us in organizations like Med Global, I think the most that we can do is continue doing exactly what you said, provide physical resources, provide you know, as much as we can in support with guidelines and things like Dr. Tabriz was a part of making guidelines. That's incredibly important to be able to provide that kind of support. And as new information comes out and new research is developed, that we continue to add to those guidelines. And then, of course, you know, what would be ideal is if the borders of the world were to open again. I think as things were to decrease in one place, if physical resources, if we were able to actually provide that, that would be great, right? But I don't see that being a part of the response anytime soon. And so I think a lot of what we're going to be doing is from a distance and providing these two things. I think this physical resources and connecting as many organizations as possible to provide those resources, such as, for instance, you know, the Cpap helmets were a really big thing here. And there's you know, there are several different companies that are able to ship Cpap helmets. You know, there are open source designs. Is there a way that can be mass produced, because it's something that, one, provides a little bit of positive pressure, some oxygenation, as well as minimizes the aerosolization, and that's something that's very concerning in places where negative pressure isn't really a possibility. So things like that, where we're really trying to upscale the response by helping improve physical resources as well as the communication of strategies of management. I think those are two big ways, but I unfortunately think it's going to get a little bit worse before it gets better. And I think the challenge will be that the world as we know it and travel to some of these countries will be very challenging because of that.
Okay. So the things that I anticipate in the future for Corona, I agree with Dr. Narine. I do anticipate things will get worse. And it'll be interesting to see what our way is out of that. In my opinion, I think that our solution will not be one of strong government responses. I think that they have demonstrated quite clearly that they are reactionary. I think that our way out is going to be through solutions developed by civil society. And that's going to be NGOs like Med Global, who are coordinating with our partners in all the different places around the world. The thing that I think that we have to offer are creative ways to maximize the things that we have, and to constantly remind ourselves that we can't really dwell on the things that we don't have, because it's not going to impact anything that's going to have to do with our patients. The other thing is that we are able to stay in communication so that we are able to provide constant surveillance for the changing needs. So Corona will, in my opinion, I think it will be a disease that will result in a continually shifting, moving target for our different needs. You know, in the beginning, it'll be the need for PPE, and then at some point it'll be, we'll say that there will be continual needs going that way. One of the things that I think we need to be careful of is the opportunity for exploitation of Corona. This is sort of a make or break situation for the way that the geopolitical community is. There will be an opportunity here for us to come together as a cosmopolitan humanity, or this will be a sort of a major nail in the coffin in the slow progression towards pluralism. And when that happens, there will be, in my opinion, I think that the ICG, the International Crisis Group, I think they're right that there will be too many opportunities for exploitation, and I don't think that we will be in a position for a long time to stop those.
Yeah, I would like to also add a few things before I talk about what can be done from here and what can Med Global and other organizations and WHO can probably provide. First of all, in terms of what is the future of Corona or COVID-19, this is so much unknown, so much we have not, clarified yet. So it's hard to project. But, what we have seen in US, and in China and other country, what we have seen is that this disease was very devastating for about 3 months, 3.5 months or so, and then it slows down, right? But we don't know if we did not do this very strict, stay home and lockdown, how would that play out, right? For example, if the New York didn't implement this, if Illinois didn't implement this, how would it go? We don't know. Because of all these things that we did, I think it, had some positive impact. So we cannot just say that, like other viruses in the past, for example, West Nile virus, it was a huge, peak, and then slowly it went away. That's different kind of vector and different kind of mode of transmission. So for respiratory virus, I think we need to just think about it's going to get worse and prepare for it. So if we get time, by lockdown and, stay home measures and so on, then we can build on, different kind of oxygen supply and infection prevention and control or so on. So I agree. I mean, this is going to probably get worse in most of the country. Now we are seeing picking up in Southeast Asia, in Middle East, and probably next in Africa too. So this is going to peak over there right now in next few months, I think. So unfortunately, most of this country will learn in a hard way. They did not prepare in last 4 months or 5 months they had. But time is still there to prepare for the next year or so, because I think if we don't prepare now, it's gonna come back again, then we'll be same situation again. So that's an opportunity at this, this crisis probably should give us some opportunity to improve our healthcare prevention measures. In another example that I think Med Global or other organization can do, for example, I know Med Global works in Cox's Bazar in Rohingya community. So I would like to add that. I mean, in Rohingya community, it's in about 1 million people there. So far, at least we know by test positive is about 38 cases, and there's only 2 deaths. So what we are seeing is there is still an opportunity to prevent, So in a resource limited country, I think 2 things go hand in hand. One is mitigation, damage control, and at the same time, prevention should be still a target, especially in area where there's not widespread cases yet. These prevention measures should still be implemented. What I meant by that in Med Global or other international health organization where the Rohingya communities actually depend on is government cannot provide or not providing much at all. So in those areas, I think quarantine and isolation, this kind of concept should be still very strictly implemented. If you have cases identified, those should be isolated, separated from their family, because all the slums are like 1 meter apart. And if there's close family member who are exposed, they should be taken away from their slum and put it in a center where there could be quarantine. That's the only way we can prevent more catastrophe in more restrained area, constrained area. So in terms of how to help with this, this resource limited country, I think what we're talking about today is one sort of example what we can do. And what I have been doing in the last 3 months and many other organizations doing is basically exchanging the information, correct information. This web-based, internet-based, learning and educating and exchanging idea is a great tool. I have done actually probably 40 to 50 hours of webinar, different kind of exchanges in the last few months. And everybody from their organization should be, doing more and more of that. And obviously, if we can partner with a local organization in any country that we're talking about, whether it's in Southeast Asia or in South America or in Africa or in Middle East, partnering with the local organization and see what they need and provide that. That kind of partnership, I think Med Global can provide more with other international organizations, including reaching out to the WHO to come up with real help, not just the guideline and protocol?
Well, I mean, this is very intriguing discussion. It opens the opportunity for future webinars about the future of Corona and how to put it under control. In the countries that were hit hard with the COVID-19, only 5% of the population have antibodies. That means 95% still do not have protection or antibodies. So we have an opportunity to prevent that. And until we have the vaccine or the medication for that, or develop herd immunity. We can meet maybe in future webinars to talk about these issues. Thank you, Dr. Mohammed Tabriz, Dr. Narina Ahmed, Dr. Riley Jones. Thank you, Denise, for coordinating this, Dr. Pareja, and also for Blair and B. And thank you for everyone who's been watching, and have a nice day.
Thank you so much.
Thank you, everyone.
Thank you.